All right, everyone, we are going to get started. Thank you for joining us for the Oncofertility Journal Club. The presenters for today is Dr. Anthony Bree, who is a REI Fellow at Stanford University, and Matthew Bolt, who is our research scientist and does the stats for these journal clubs. And the title of this presentation is Live Birth Rate After Female Fertility Preservation for Cancer or Haematopoietic Stem Cell Transplantation, a systematic review and meta-analysis of the three main techniques: embryo, oocyte, and ovarian tissue cryopreservation. And we selected this article because, every day our field is changing and we have more data on a regular basis, and we're always trying to determine what is the best option for our patients, particularly as it relates to ovarian tissue cryopreservation, and what do we know today. So, Anthony, you may proceed. You may put your questions in the chat and I'll answer them. I'll ask them at the end, or you can unmute at the end and ask the questions yourselves. Thank you.
Great. Thank you, Dr. Appiah. Like you said, I'm Anthony. I'm one of the fellows at Stanford. And Matt, you want to introduce yourself briefly?
Yeah. Hi, I'm Matt. I'm a researcher in the Department of Biostatistics and Informatics at the University of Colorado.
And we'll be presenting this systematic review and meta-analysis today. Here we have no disclosures. Okay. So fertility preservation has become a major public health issue in the care of women with oncological pathologies. Fertility damage from cancer treatment has a high impact on the quality of life in these individuals. There are three contemporary methods for fertility preservation that are generally recognized. These are oocyte vitrification, or egg freezing, embryo cryopreservation, and ovarian tissue cryopreservation. Of note, the European Society for Human Reproduction and Embryology regards ovarian tissue cryopreservation as an innovative technique, whereas the American Society of Reproductive Medicine regards ovarian tissue cryopreservation as an acceptable technique. In contrast to oocyte and embryo freezing, ovarian tissue cryopreservation has the potential to restore spontaneous fertility as well as endocrine function, and is the only available option for pre-pubertal individuals. It is imperative to provide appropriate fertility preservation counseling. However, as Dr. Appiah mentioned, lack of data and practice variability worldwide have to date made this counseling challenging. So therefore, the purpose of this study was to provide a systematic review and meta-analysis of reproductive outcomes following these three fertility preservation techniques in female cancer survivors and patients imminently undergoing gonadotoxic treatment. And so the initial screen included studies involving females with cancer or who are undergoing stem cell transplantation, who had undergone fertility preservation with subsequent use of their cryopreserved gamete or ovarian tissue, and for which cumulative live birth rate was reported. Studies published in English or French between June 30, 2001 and January 1st, 2024 were identified from the PubMed, Embase, and Cochrane Library archives. The main independent exposure was the fertility preservation technique, oocyte vitrification, embryo cryopreservation, or ovarian tissue cryopreservation. The primary outcome of interest was live birth rate. Secondary outcomes of interest included percentage of women with at least one live birth, rate of miscarriage, and rate of ovarian function restoration in the setting of ovarian tissue cryopreservation. The methodological quality was selected studies was assessed by 6 independent reviewers using the Cochrane Handbook methods and the Newcastle, Ottawa Quality Assessment Scale cohort case control studies. Risk of bias was assessed using the Robbins tools.
All right, so I'm going to give some background on the statistical techniques used in this paper. Typically speaking, meta-analyses are used to summarize a bunch of papers that may or may not demonstrate associations between dependent and independent variables. So if you have studies A, B, C, all the way through Z, and they all study sort of the same thing, but you want to summarize the information, that's what you would use a meta-analysis for. And it's really useful in the field to get final as we can get. That is, final answer for the relationship between the two things that you're studying, and just a very good summary overall of the status of the field. However, the paper we're looking at today is a lot more descriptive in nature rather than analyzing specifically the relationship between any treatment and outcome. It's looking more specifically at just the rate of outcomes and success over time in these 3 different fertility preservation techniques. It's very helpful that in that regard to give clinicians an idea of how to counsel people and what to expect coming up. Of note, the paper analyzed these 3 methods separately. It's not a paper that's intended to compare methods. Again, unlike most meta-analyses that summarize associations, this one's just very descriptive to give you an overview of what's been found and to summarize that in a statistical manner. Next slide. All right, so the main thing that we need to study when we look at meta-analyses are forest plots. You can see the forest plot on the right-hand side here. It's kind of like a table. It's kind of a visual, a little bit of both. You can imagine it, though, as a spreadsheet where each row represents a study and each column represents some data about that study. And so here we have 7 studies presented in this forest plot, and it's the forest plot specifically looking at success rates of ovarian tissue cryopreservation for all the studies that this meta-analysis included. And so we'll take a look at the first row here. In my row 2016, we see that the cumulative live birth rate that this paper presented was 0.3, which you see under the proportion column. And there's a nice confidence interval for that going from 0.1 to 0.5. And that's represented visually in kind of that middle graphic row. And you can see there's a point estimate kind of around the 0.3 mark if you follow that down to the proportion legend on the bottom. And then the confidence interval is also presented visually. And so row by row, we just have a bunch of studies. And from each study, we have the cumulative live birth rate under ovarian tissue cryopreservation. And we can see not only how these point estimates vary across studies, but also how variable these point estimates are within the study, which is kind of captured by those confidence intervals. The other column you'll want to make note of is the column with percentages in it, starting with 7.52, 16.54, and going down to 4.14. These percentages just talk about of all the samples that make up a big N, a big sample size for this study, you can see the proportion of information that each study contributes. So, for example, the third row from the bottom, Dolman's 2021, that seems like it was a pretty large study because it contributes almost 41% of the information about ovarian tissue cryopreservation to this meta-analysis. So now that we have an idea of the central element of the meta-analysis, the forest plot, you may be wondering, what do we do with this forest plot? We collect all this information. How do we combine it? And the way you kind of combine the information from this forest plot is you just average it pretty much. And you can see that at the very bottom row under Vattel 2021, there's kind of some statistical jargon. And then the bottom row, final right column, you have a final overall proportion, 0.19, with the confidence interval going from 0.15 to 0.24. And this is saying, you know, we took all these proportions, we kind of averaged them, and this is our final average. I will say the average is not the normal average that you're used to of just adding all the numbers and dividing by the number of numbers you have. Meta-analyses use special tools to average these values. They give more weight or more value to the samples that are larger and less weight to the samples that are smaller. So really, it's pretty straightforward, just a very, I won't say simple or complex maybe, but it's just a mean in this scenario, just not quite the mean that you're used to. You want to go to the next slide? The other thing that's important to know about forest plots and meta-analyses and how we're making this final overall mean is not only are meta-analyses nice for getting a final answer or a final estimate of an effect, or in our case, just a final proportion. It's also very helpful to understand the variability in the studies that we're looking at. And you can see the reason for this is because if you have a lot of studies that are very similar, they're very easy to combine. If you have a lot of studies that aren't so similar, they might not be so easy to combine. And the philosophy behind this in a lot of statistical inference is that we assume that every time you do a study, you're studying some sort of effect that's out there in the real world, and you're trying to get a glimpse of that effect. And so you run a study on a sample, and then for based on the sample about the population. However, you could assume that instead of one effect being out there, which we'll call the fixed effect, that would be the effect that happens for all people, there might actually be different effects for different populations. So for example, a younger population might have an overall effect that's different than an older population, or a European population might have a different effect than an American population. And so what is helpful in these meta-analyses is to determine kind of, are we studying the same effect here all the time, or do we think there's a variety of effects that we also need to account for when we're doing this averaging? And when you assume that you have the same effect throughout, you call it a fixed effect. And when you have different effects on different populations or ages or locations, you're going to call that a random effect. And we don't need to get into the weeds about how these models are different. Just know that the averaging is slightly different to get that bottom value. The other thing that's helpful to know about fixed effects versus random effects is that fixed effects are typically going to be used when there are more consistent findings. So in the image on the right on the top, I think that's from plot C in the paper. You can see that they used a fixed effects model because they thought the effects were all the same across the studies they were using. But in the bottom image, you can see that they used a random effects model designated by the RE in that bottom left corner. And this means that the authors thought there may be more than one effect that they were studying, and they had to adjust for that accordingly. Finally, the last statistical stuff you might want from a meta-analysis is measuring this variability and seeing if this variability is due to there being different effects, or if it's just sampling variability that every study has to deal with. And so the value that you can look at for that in the meta-analysis is this I-squared value. This is a value that goes between 0 and 100, which basically answers the question of all the variability I see in my study. You know, some studies are low, some studies are high. What percent of this variability is due to real differences in effect size, like under a random effects model? Or what percent of this variability is just due to the nature of inference and doing science on human populations, where things are just hard to measure, so they vary? Again, looking at the plots on the right-hand side of the page, we see that the I-squared statistic here is 18.5% in the top image. So only 18% of the variability observed in this meta-analysis is due to the actual effects. So we're kind of seeing that a lot of the effects are the same. Whereas in the bottom here, we see an I-squared of 46.1 in the lower plot, and that's saying in this specific subcomponent of the meta-analysis, the effects seem to vary a lot more. And you can also see that they use a random effects model then for that. Next slide. Okay, so that was a lot of information, but the key takeaways from this meta-analysis is that we have a forest plot and we can show all the effect sizes. Basically, what we're doing is just taking a fancy average of those effect sizes to get an overall effect size. We also do a fancy average to get the confidence interval for that effect size. And then if we want to know if there's one effect that we're measuring or multiple effects, depending on the population that we're measuring, we can look at the variability of those effects with an I-squared statistic, which also kind of informs the type of model you might want to use, being a fixed effects model or a random effects model. I think that's it.
Now moving on to results. So this is the Prisma flow chart of the studies that were screened and ultimately included in the meta-analysis. 14 studies evaluating embryo cryopreservation, 8 studies evaluating oocyte cryopreservation, and 15 studies evaluating oocyte tissue cryopreservation were ultimately included in this analysis. For embryo cryopreservation, like I said, there were 14 studies which encompassed 1,779 women, including 160 women who had returned to use their frozen thawed embryos. One of these studies had a high risk of bias, and that was noted due to missing data. The age at embryo cryopreservation ranged from 25.4 to 37.5 years across the studies, and the average number of cryopreserved embryos ranged across the studies from 4.1 to 11.3. Looking at the results, the live birth rate was 41%, and the percentage of women with at least one live birth was 43%. the percentage of women with miscarriage after frozen thawed embryo transfer following embryo cryopreservation was 22%. As you can see, the I-squared values for these estimates were low, indicating that there was consistency across studies. And so these were fixed effects models, as Matt was alluding to earlier. For oocyte cryopreservation, there were 8 studies which were included, encompassing 3,851 women, of whom 178 chose to return to use their frozen oocytes. The risk of bias was noted to be low for all of the articles included. Age at the oocyte freezing ranged across the studies from 15 to 45 years, and the mean number of frozen oocytes ranged from 5.9 to 5.9 to 9.5. The live birth rate estimate following use of oocyte, frozen oocytes was 32%, and the percentage of women with at least one live birth was 32%. The percentage of women with miscarriage was 11%. Again, you can see that the I-squared values were low, indicating good consistency across the studies with these estimates. Moving on to ovarian tissue cryopreservation, there were 15 studies which were included. Amongst these studies, 7 reported orthotopic transplantation, 1 reported heterotopic transplantation, 4 reported both, and 3 did not provide this information. 2 of the studies were noted to have a high risk of bias for the selection due to selection of participants. And the time between the oocyte tissue transplantation and the first menstruation varied from 3.9 to 94.3 months, kind of indicating a heterogeneity in the study populations across these studies. Different options. So it should be noted that there are 2 different options that exist for attempting conception amongst this group of patients. You can let the patient try to conceive without assisted reproductive technology, or you can proceed with IVF. And you can do either of these with or without retransplanting the ovarian tissue that you had previously preserved. And so with that in mind, the live birth rate following IVF after ovarian tissue cryopreservation, but without subsequent ovarian tissue transplantation, was 19%. The unassisted live birth rate following ovarian tissue transplantation was 33%, while the live birth rate after ovarian tissue transplantation and IVF was 17%. The percentage of women with at least one spontaneous live birth was 32%. The percentage of women with miscarriage after ovarian tissue transplantation was 14%. The rate of ovarian function after ovarian tissue transplantation, return of menses, was high. And so in order for the authors to be able to generate a point estimate for to look at ovarian function restoration, they actually looked at the opposite outcome, which was the rate of no ovarian function restoration, and they calculate that at 6%. You can see that for the miscarriage and spontaneous unassisted live birth rate following ovarian tissue transplantation estimates, the I-squared values were relatively high, and so these ended up being, as well as the women with at least one spontaneous live birth, the I-squared values were high, and so these ended up being random effects models. And so this meta-analysis provides live birth rate estimates for the 3 contemporary fertility preservation techniques in the setting of female cancer or stem cell recipient patients. It is important to remember that the purpose of the analysis, just as Matt was mentioning earlier, was not to compare the effectiveness of these techniques, but to help facilitate counseling for the patient. As we know, the type of fertility preservation technique chosen will depend largely on each patient's individual clinical and personal situation, which inevitably will impact the live birth rate. While embryo cryopreservation was associated with the highest chance of achieving a live birth from this meta-analysis, it does come with loss of reproductive autonomy relative to the other methods. For example, the ethical and legal concerns that would arise in the setting of a couple breaking up or in the setting of the death of a partner. On the other hand, while ovarian tissue cryopreservation yielded potentially the lowest live birth rate in the study, it is the only option to preserve fertility in pre-pubertal patients, And additionally, it carries the advantage of potentially restoring endocrine function and therefore could be good to consider in patients with high risk of premature ovarian insufficiency. The strengths of the study are that it include that it's the first meta-analysis to compare data of all contemporary fertility preservation techniques in the setting of oncofertility. It utilized strict methodology, including an assessment of bias and sensitivity analyses, including comparing the fixed effects and random effects models when it was indicated. Finally, it provided detailed information about live birth rate that will prove valuable to professionals and women in this situation. Some limitations of the study are that only observational studies were available, and most studies had a small number of participants. Additionally, there was missing data regarding spontaneous pregnancy, as well as lack of information on patients who did not return to use their gamete or ovarian tissue. Furthermore, there was heterogeneity of IVF protocols utilized throughout the studies and a limited ability to evaluate the efficiency of these protocols. So in conclusion, the systematic review and meta-analysis provides guidance when counseling oncofertility patients about fertility preservation techniques. A combination of different techniques could be the best option, but this requires further investigation. This meta-analysis highlights a need for an international registry with standardization of the reporting variables, as well as standardization of oocyte and embryo freezing protocols in order to facilitate comparison between centers. Thank you.
Thank you, Anthony and Matt. That was great. Thank you. Thank you. There's a question in the chat. Was return of menses the only measure of restoration of ovarian function? Meaning, were there any laboratory analyses that were performed as part of restoration of ovarian function?
So that's what I could see from this from reviewing these studies. And you know, they did they didn't specifically indicate in their review what the definition of return of menses was, but they did note that there was a range in terms of when menses returned, which, in order to be consistent, was utilized as a definition for return of menses.
Okay.
The authors for the meta-analysis itself did not report any other metrics to specify definition for return of menses.
Okay. Anthony, can you go to the slide where you show the outcomes for the oocyte, the 15 papers on oocyte? Just, okay, not oocyte, I'm sorry, ovarian tissue.
There it is.
Okay, so live birth rate, women with at least one spontaneous live birth, so 32%, yes?
Yeah.
And for the oocytes, it was similarly 32%?
Yeah.
Okay, and then embryos 41%.
Yes.
Okay, so I mean, I know the conclusion says it was lower than the others because there's so many different outcomes that they looked at, but I mean, that's 32 and 32%. And I think the data that we've seen on some of the other cumulative reports ranges from 29 to 41% live birth rate, but that also includes IVF. And it looks like this 32% did not include IVF, right?
For the ovarian tissue cryopreservation, yeah, they were able to stratify IVF versus not IVF. That's correct.
Okay. I have a question for the REI people here. So we keep reading that the live birth rate is higher with spontaneous conception than with IVF. We've seen that in many papers. We see that here. Do we think this is simply a function of the tissue's not working as robustly as we would like for spontaneous conception? So when you're going to IVF, you're already kind of behind the 8 ball because the tissue is already not functional? Or do you think that there's something about the IVF process, stimulation, retrieval in the setting of transplantation that makes these birth rates different, that makes the birth rates lower?
Great question, Leslie. It's Glenn. And we just got back from Tokyo and everyone was presenting their data, a lot of it about ovarian tissue freezing and transplantation. The issue, I think, is In fact, about half the pregnancies happen, and these are patients confirmed menopausal, so no ovarian function. So I think the problem with this study is, as Matt was saying, it's very descriptive and it's very heterogeneous. You know, what did the patients get? How much tissue was put back at a time? How old was the patient when they had their tissue frozen? You know, did they have chemo before or not? So all these things really affect outcomes. But half of the pregnancies happen natural conceptions after the tissue is transplanted back. About half happen with IVF.
Right.
The problem was saying, okay, the pregnancy rate is X%. Natural conceptions, you have multiple months of trying to get pregnant, and your pregnancy rate after 6 or 9 months or a year is X%. With IVF, since the tissue doesn't function as well, I mean, it's very, they become DOR patients when they go through IVF. You have a single cycle with 2 or 3 eggs being retrieved. So you're comparing a single month of IVF and stimulation to 9 or 12 months of trying on your own. And I think that's where some of the discrepancy occurs in outcomes data, looking at sort of this descriptive type study.
Gotcha.
Leslie, I want to add to that as well. I mean, this is Maytal. We know that if you're going to do IVF after ovarian tissue transplantation, you want to do it quickly because the tissue they're going to turn into DOR patients as time passes by. So it's hard to know whether these patients, exactly what Glenn mentioned, have been trying for a year and then doing IVF, and they have worse outcomes with IVF because they're now, quote unquote, you know, older from a DOR perspective. So if they're going to do IVF, the best success rates are going to be early on in the tissue transplantation process once the transfer has occurred and the endocrine function is resumed.
Perfect. Right.
Did
Okay.
you find it surprising that the pregnancies happen even with retroperitoneal transplants? You still have natural conceptions if there's a tube on that side. So I thought that was really interesting in terms of the outcomes data, that you don't need to do autologous transplants into a orthotopic location. They can be a peritoneal implant and still have natural conceptions.
Yeah, I think that's amazing. People always get their minds are blown whenever we show that data and show those images. So that makes sense to me, because not a lot, but some patients choose ovarian tissue cryopreservation because they don't have to pay for IVF, right? The laparoscopic oophorectomy is covered by insurance. The transplantation is covered by insurance. So yes, naturally they're going to want to try to conceive as long as they can before they pursue IVF, at which point they're looking at some DOR because of the atresia that occurs. Okay, that is my question. Any other conversations? So I guess the question is, how would we use this paper? So the purpose of this is to help with counseling, right? Supposedly. So then how would we use this paper, Anthony, you think, in terms of counseling patients about options, not necessarily always comparing the three, but what they can anticipate?
Yeah, so, you know, I think what I'm saying is that the options they have are, I would imagine, are kind of guided by their current situation. There may be patients who may not have time to undergo an IVF cycle, and it's possible that the only option will be tissue cryopreservation. And then there are patients who, you know, might be unpartnered, and so for them, the question might be, like, do you want to pursue donor sperm, or do you want to freeze the eggs? And so I think, you know, kind of outside the oncofertility setting, you know, we often counsel patients about the attrition that happens from, you know, egg to embryo. And I think that applies certainly here. And I think that can be used to explain somewhat the differences between the live birth rate estimates for embryo versus ovarian tissue cryopreservation. But really, the way I see this is it helps to guide and manage expectations. It helps to give a patient a sense of what they might be able to expect in terms of their fertility, given the treatment path that they're probably set down on by virtue of their situation. And it just helps to provide a little some expectation, some guidance for them in the future when they return to try to conceive. And I think that's the most value that can be given from this data.
No, and Anthony, that's great. I want to make one comment for the group, and I think that this is really important to understand that when you look at the egg freezing data and the embryo freezing data, it doesn't talk about the age at freezing, really the number of eggs that were thawed, the outcomes. So it's important we counsel patients that, first off, you can stimulate eggs in a prepubertal patient. I mean, we talked about that last time, Leslie, right? I mean, that's something that we can do. But autonomy over the gametes is critically important. And, we talk about egg freezing outcomes in an older patient are not as good. Well, that's okay. And she's giving herself a chance. I don't think we should be, and I counsel patients all the time, we should freeze eggs, even if the success rates are slightly lower than freezing embryos. So I don't think we should just look at outcomes and say, okay, make embryos so it's a little better outcome. We should encourage freezing eggs because situations change all the time. And even if the outcomes aren't as good, it's better for the patient when they call you up and say, can you unfertilize my egg because I'm no longer with my partner? That's not a fun conversation to have. So even if the outcomes are not as good, we shouldn't look at just outcomes. We should look at the patient's future and reproductive goals.
I completely agree with that. Jacqueline, you came off mute. Were you going to add something?
I mean, I completely agree with Dr. Chapman. I think another really important point about table 3 is that all of the data from the ovarian tissue cryo, the age that the tissue is frozen at, on average, they're all in their 20s. And I think the majority of patients that we're counseling and doing OTC on, or at least my whole population, they're all less than 20. And so I think that that is a big gap, which obviously we can't answer because we don't have enough patients to look at the children and the teens because they haven't come back yet. But I think that that's a big piece is when those patients return, like how are they going to function? The prepubertal girls, how long is it going to take for that tissue, for the HPO axis to reactivate and because they have a higher density of eggs or how many pieces? I think that's a big hole that this paper doesn't answer when I counsel patients of the different options. But I think it's a good paper.
Yeah, and I think this whole conversation is making me think about our HOPE database, right? As we are collecting, we're creating the database, reproductive health database. It will be an international database for fertility preservation, where institutions will be able to send their data to the central repository, and the date will have a data dictionary. You'll have to harmonize your data at your institution to reflect the data dictionary, send data, and then be able to ask for data to write papers. And I think as we are creating the data dictionary, having as many potential variables there as possible to capture a lot of this data is really important, with the understanding that, there's a minimum amount of data that we're going to want, but the more information we have, the better we can answer some of these questions in a more robust fashion. So I am thinking of that as we do this. I have another question for our REI colleagues. This conversation about vitrification versus slow freeze of oocytes, and we should all be, or you should be doing vitrification, but it depends on who's doing the vitrification in terms of success rates. Like, how real is that at this point? Like, are you all doing vitrification? Are you all doing it at the same level of excellence? Can patients expect that one location freezing their eggs is going to be as successful as another? I know there are always different techniques, but what is the final word on this vitrification and success rates, if that question is clear?
Leslie, great question. I don't think anybody has a slow freezer anymore. I think every single lab has gotten rid of their slow freezers. Good. So I think everyone's vitrifying eggs and embryos, and I think the success rates are relatively similar because they're all standardized kits now. Okay. The difference is, and I'd like to ask the group in terms of ovarian tissue, we're still slow freezing ovarian tissue. There are some new papers about vitrification of ovarian tissue, but there's not a lot of data about outcomes from vitrification. So I think if you got rid of your slow freezer, you're probably going to want to, dig it out of the trash and maybe use it again.
Yep.
For the
Hi,
tissue.
everybody.
Yes. This is
Sangeeta. Thank you. Yeah, what Glenn said, we all vitrify. It's so standard. We've been doing it for over a decade, 15, 20 years now. Oocytes, embryos, kits are interchangeable. There's universal protocols, no problem. To his point, though, frozen eggs tend to perform a little less well than fresh eggs. But we all know that now. I don't think we can pretend it's not a thing. It's actually a thing, but okay, it comes with pluses as well. As for the tissue, we also slow freeze. There is a vitrification protocol, which I don't think is standard of care yet. And the VIT kits are always back ordered. So it is a bit of a challenge to actually operationalize the VIT, which makes sense to do because that's what we do now. Yeah, I've got a slow freezer in my labs for ovarian tissue.
Maytal, were you gonna say something?
Agree with everything that was mentioned. I think the oocyte cryopreservation rates are pretty standard. I mean, ours at Brown are over 90-95% survival for eggs, maybe a little bit better for embryos, but overall pretty close. We are also pulling out our slow freezer if we start ramping up ovarian tissue cryopreservation again. We obviously stopped using it because we're vitrifying embryos and oocytes. I don't think that there are many clinics vitrifying tissue in the US. I know there's a few, but currently we're looking at using our slow freezers to ramp up the ovarian tissue program again.
Can I ask a question to the group when everyone's here? Is there an age cutoff or an egg reserve or an ovarian reserve cutoff you have for ovarian tissue? Is it 35? Is it no age limit? What's the age limit? Because we talked about egg freezing and there's some limitations of freezing eggs, but is there a cutoff at which you will not offer ovarian tissue freezing for a patient?
The recommendation has been age 35. However, I think that's too arbitrary, right? Like, I don't understand why we would not assess the ovarian reserve and see what's there before we decline offering it. But the data, I believe, has shown that there have been no live births from ovarian tissue transplanted, the ovarian tissue harvested over age 35 and then transplanted back. So that's why the recommendation has been not to remove it after age 35. And that was the data, I think, as of 2021. But I don't know if there's new data.
There is some data up to 38. There's nothing over 38, but there is some data. There are some pregnancies up to 38.
38.
But there's no ovarian tissue, no ovarian reserve measurements that are done. So you may have a 38-year-old that has an AFC of 40 or 50. Should we offer to that patient?
Yeah. I say yes. I know that the integrity of the follicle is different, right, as they age, but I don't see why we would withhold it if there is some reserve. I see Mary Zielinski's on. Mary, did you want to comment on vitrification of ovarian tissue? Maybe she's not.
Hi, I'm here. I'm driving in my car. Sorry. So you're right. There is only one VIT kit available. There are problems getting them. We're working through the Oncofertility Consortium with a small startup company that is trying to get a VIT kit available for use in the US, and that has gone through all of the FDA approvals. So this is going to take a while because the media has to be prepared under GLP conditions, et cetera, et cetera. And we don't really know how many pregnancies the FDA is going to require in order for any VIT kit produced here to go through approval. So just know it's all in the works, and the only data out there is from Japan. I don't like when we try to say slow freezing is better than vitrification because, as you all mentioned, there haven't been as many attempts at transplanting vitrified tissue. The success is that there are live births with both techniques, so it remains to be seen if one is better than the other. I would just like to make a comment about the spontaneous pregnancies. I parked my car now. And that is, I've not seen a paper that has shown that the spontaneous pregnancy actually came from the tissue that was transplanted. So let's say that one ovary has remained and you assume that it is non-functional. You transplant tissue orthotopically to the other ovary, and you don't know where that egg came from. I think it would be fairly easy to figure out just by an ultrasound, seeing where the corpus luteum was. But I haven't seen any papers that can really say where that pregnancy has come from. And especially even noting whether there's a CL in the heterotopically transplanted side. So that's just a comment I have. Thanks.
Yeah, Josh Johnson, our ovarian biologist, always reminds me of that as well. Does anyone, thank you, Mary, I appreciate your input. Does anyone have any comments to Glenn's question about ovarian reserve testing for patients over age 35, 38 before deciding not to transplant or transplant? Anybody else having those conversations? I know that we have not done ovarian tissue freezing in anyone over age 35, but maybe we'll push it to 38. I'll look at the paper. But any other experiences? Jacqueline, I know you're taking care of kiddos, so.
No, our protocol is from 6 months to 35 because of that one paper, but I mean, I think it's reasonable to do an AMH and an AFC, and if, you know, they have a good AMH or AFC, like I don't see why you would exclude them from offering that if that may be their only option.
Right.
It should be individualized.
Leslie, can I make a comment on that also? You might see success rates rise in these older patients if people took the time to actually put back pieces that you know had follicles in. So when you slice them and cut them, nobody looks at them before they go in the freezer. And depending upon how thin you slice the tissue, you can actually see primordial follicles under the microscope. And you could sort out pieces that have absolutely nothing, which you know there are going to be a whole bunch in patients that are 35 or older. So if there was a little more selection as to what was saved and what was transferred, the success might be better.
Thank you. Excellent point. Okay. All right, we are at 11:45. Are there any other thoughts, questions? I appreciate the dialogue. I hope it was helpful to others. Our next journal club is going to be in March, and Dr. Shatman's team will be presenting, and we will send out the article here shortly. We will then take a break, and we will resume in September when the second year fellow at Stanford will present an article.
And if anybody has any interesting articles they'd like us to look at, please send them along. We'd like to look at them too. So that'd be great.
Yeah, if you read anything that you feel it deserves some more discussion, it'd be great. Thank you all for your engagement, and we will see you next time.
Thanks, Leslie.
Bye. Thank you, Anthony. That was excellent. Great job. Thank you, Matt, as usual, for explaining what a meta-analysis is and what to take away from it.
Great job.
Bye-bye.
Thank you.